Welcome to the Approaches to Quality Sleep Culture conference call. My name is Vanessa, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will have time for your questions. If you like, you can submit your questions throughout the call using the chat box. We will save time at the end for phone questions as well. Please note that this conference is being recorded, and I will now turn the call over to your host, Leah Brandis.
Hi, thank you everyone for joining our event today. And we will be making sure that you get the copy of the slides through email after the presentation today. And we do have a chat monitor, so you can put questions in the chat box, and Crystal will be monitoring that. Also, I'd like to inform everyone that today's presentation is being recorded, and we hope to have that available on the Comagin website in a couple of weeks. And for those who are logged into our Zoom webinar portal, you will be muted for the duration of the webinar, so please use that chat box. And today's presentation is on approaches to quality sleep culture in long-term care. This presentation is sponsored by the QIO, Comagin Health, as well as the Great Plains Quality Innovation Network. My name is Leah Brandis, and I am the lead for our nursing home collaborative at Comagin Health. Today, we are fortunate to have staff from 2 nursing homes present their journeys in implementing a quality sleep culture. We will hear from Margaret, who is the Director of Nursing Services at Avamere Rehabilitation of Eugene in Oregon, and Deb Sutton, who is the Administrator of Jefferson Community Health and Life at Gardenside in Fairbury, Nebraska. Hang on, I'll try to move my slides. There we go. Okay. So before I introduce Margaret, I want to give you a little context. In 2017 and 18, Margaret and her administrator participated in the QIO Collaborative and attended all 6 of the learning sessions over the 18-month period. The quarterly learning sessions were based on the 6 modules of the Agency for Healthcare Research and Quality Safety Program for Long-Term Care, HAIs, and CAUTI Long-Term Care Safety Toolkit. The titles of the sessions were Applying Safety Principles, Senior Leader Engagement, Staff Empowerment, Teamwork and Communication, Resident and Family Engagement, and Sustainability. They applied what they learned to the new Quality Sleep program. So now I'd like to introduce Margaret.
Hello, thank you. It's a privilege to be able to share with you the Avamere Sleep program. We did work on this together with our administrator, Chad Martin, who was unable to be on the call today, but definitely played a major part in putting together this sleep program. And as Leah said, we did attend the collaborative and just learned so much and was able, I think, to be successful with this program based on what we learned and the encouragement we got from the collaborative. Next slide. So during the collaborative, we had the opportunity to take the AHRQ Nursing Home Patient Safety Culture Survey. And when we got the results back, we were surprised to see that only 54% of our staff agreed with the statement, it's easy to make changes to improve resident safety in this nursing home. And then only 61% agreed with the statement, this nursing home is always doing things to improve resident safety. And we realized that there was a gap there and that we really did need a performance improvement project. Next slide. Next slide. Okay, thank you. In taking a look at what projects we did consider sleep because we had been encouraged by our regional consultant after they went to a conference and heard about how sleep affects the elderly. And what they learned from different research studies was that the falls decreased. It affected people fall more often if they're not sleeping well at night. They have poor cognitive function during the day, and I think we can all relate to that if they don't get enough sleep during the day. The sensory processing, the behavioral stress, just you see all kinds of behaviors from people, and I know even myself, you get irritable when you don't sleep. Pain tolerance was also less. Mobility, it decreased in even the healing process was less when you don't get enough sleep. And then just overall, their quality of life. Next slide. So we took a look at what we wanted to do, our performance improvement project, from a quality perspective. We wanted to share a vision of what we wanted. We wanted to challenge our current process, and it was a challenge because, as many long-term care nursing staff know, there's a certain way you do things on nights, and you just don't change that. And that was something and I'll talk about that later, what we were planning to challenge. And then allowing people at the lowest level, and our CNAs are so important, but enabling them to act and do what is right, and then evaluate, encourage the heart. The sleep program, when we looked at it, it did involve all four elements, and we said this will be a perfect project for us. Next slide. So this was our vision. We wanted to have a sleep program, and we thought, well, how could we help people sleep better? So first thing we thought about was the lighting. There are a lot of people that are sensitive to lights, and those bright hallway lights or turning lights on when you go into the room at night to check on a patient really did affect people's sleep. So we went to mood lighting. What we did in the hallways was we turned on every other light and just kind of put in less intense bulbs. And then we also used a hands-free staff light. It's almost looks like a necklace. It wraps around your neck with a light on each end that you could use. That one takes a little bit of getting used to. The first couple nights we had staff who didn't quite know how to use those neck lights and were shining lights right in patients' faces. But eventually it did help overall to keep the lights down. And then the Yacker tracker. The Yacker tracker was implemented to help decrease noise. And what it does, it looks like a stoplight, and it turns red if your noise is too loud, yellow if the noise volume goes up, and then green if your volume is an appropriate place. We eliminated overnight paging. TV headphones, we did have some residents that played their TVs quite loud at night, so the headphones were what we wanted to put into place so that that TV volume was decreased. We adjusted the walking round so we weren't going in and actually checking on patients inside the rooms in the night. The stocking schedule, not shift traditionally, would go in and stock the closets in the rooms every night, and so that was something that we had to adjust. The cleaning schedule, wheelchair cleaning, they would go in, grab their wheelchairs, clean them, bring them back in, all those little things that disturb people's sleep. Resident and family engagement, we had to meet with each of the residents and family to talk about the sleep program prior to starting, so that we would, they would know what the program entailed, and also wanted to be able to assess the resident to see if they would be appropriate for the sleep program, because it would involve leaving them to sleep during the night, and there was some residents that just were not clinically stable enough to be left alone without actually going in, taking vitals. So we had to do an assessment prior to putting them on the sleep program. And then we changed the med and treatment times. What we aimed for was, if there wasn't any reason for us to go in the middle of the night and give them a medication or a treatment, that once they fell asleep, that they would actually be allowed to sleep without having to wake up. For the most part, that was pretty successful. The overnight incontinent products, we had to buy overnight briefs, something that would, in case they were incontinent, that would hold them and allow them still to be comfortable while they were sleeping. And then decreasing the fluid intake after 5. So during the day, we'd give 8-ounce cups if they wanted something to drink. But in the evening time, we switched, in dinner time, switched to 5-ounce cups. And so we were giving them less to drink, so hopefully they wouldn't have to get up and go in the night. And then, again, as I said, all residents were assessed prior to the sleep program, and we actually identified which residents were part of the sleep program by putting a little picture of a moon on a tiny picture, it's about 1.5 by 1.5 inches, of a moon on their doorway by their nameplate. And then the lavender infusion was something that we would start about 8 o'clock at night at the nursing station and then halfway down the hallway. And I actually had a resident tell me, "What is it that you're putting in the air? It's making me sleepy." So it was effective for some. And then we purchased some quiet please signage. So when it came to be 8 o'clock at night, we put them at the heads of the hallways just to say and remind people to be quiet. Next slide. Next slide, please. Okay. We did have some barriers to success. As I said before, it was the whole culture change. And for the night shift, they were just used to going in and checking on residents. And I did have a staff actually ask me, "But what happens if they die and we don't find out about it till morning?" They were so worried that something was going to happen if they didn't actually go in and take a look at them every 2 hours. So that was, and it was also a culture change for them to not go in and stock the rooms and do the things that they did at night. They said, "Well, what are we going to do then?" Staff training, we had to make sure that everybody knew what was the program, but it wasn't just the night shift, the evening shift because they started the program, and then day shift because they ended up taking some of the duties of the knock shift. And then the equipment, we had to buy some equipment. There was some environmental modifications with the lights. And so all of those were barriers to potential success. Next slide. So staff feedback, what we found out was that our overnight brief product didn't come in a bariatric size, so we had to right away find something else. That first night we realized, oops, doesn't fit all. And then if on the slide you could see that little note, that was tucked under my door after the first night when I came in. And what the staff did, they were so worried that these patients were not going to be able to sleep with a wet brief, is that they went ahead and checked them anyway, even though we said let them sleep, don't wake them up. They did it anyway because they just wanted to make sure that they weren't going to be soaked and needed sleeping in a wet bed. So again, that was part of the culture change. When we found out some of the headsets didn't work with the TV, the headsets that we bought, so that was something that we found out right away. Again, the culture shock for the staff, particularly day shift, because now they were doing things like the stocking in the rooms that the knock shift used to do, and it was, just something that they hadn't done before, and there was a lot of saying, I can't do this, we don't have enough time for this, and again, just getting the staff on knock shift to let the patient sleep. The staff needed an identifier to know who was on the program as they went down the hole, who they could check on, who they couldn't, and so that's why we put those little moons on the doorway. And then the staff indicated they felt more relaxed, and I thought that was interesting. What we found out when we turned on the lavender, when we turned on the lights, when everything kind of calmed down, the staff also calmed down. They said, "Wow, it just feels so much more relaxed around here." Again, the day shift was busier. There was that resistance to picking up night shift duties, or what they considered night shift duties. We did have some trouble with the lights. As I said, we didn't train on how to use lights. We just said, "Here's your neck light," and then people would lean over and those lights would shine right in people's eyes. And so we figured out we needed to do some training with the lights. But there was staff pride in the program, and I think that I say right away that the staff felt they were doing something special, something different, something unique, and nobody said, "I don't want to do this program." And they all they had their pieces of how they wanted to tweak it. But overall, I thought that there was a great acceptance for that. Next slide. So teamwork and communication. We did that by writing up some guidelines. We did rounds. All the administrative team walked around and talked with the staff. And then we had a QAPI and a subcommittee, a sleep committee, that we also use to communicate what the difficulties. Next slide. So before we started the program, we thought about what we wanted to do, what we wanted to measure. And the things that you're seeing on the screen are the things that we decided we're going to take a look at these things to see if this sleep program actually makes a difference. And what we did was we took a group, and I actually did a random sample of our residents on the long-term care, because that's where we piloted the program, and then took out anyone that maybe potentially was going to be discharged, would not be there for a length of time for us to be able to measure, or if they were on hospice, I took those people out. So let's take a look at how we did with those metrics. First one was falls, and as you can see here, that was the measurement was the number of patient falls on Diamond. That was falls per month, and that went down. That was a real win for us. Next slide. For scans, what we took a look at was the number of wounds that we were currently treating on that unit. I'm talking pressure injuries in particular. And there was a little bit of hesitation because people were on turning schedules, especially if they had already a pressure injury. And it was very difficult for staff, and again, that was a culture change to say, wow, you're going to let them stay in the same place all night? I don't know about that. But they did, and what we found out was the wounds healed. And some of those wounds had been there for a long time, so that was a real success for us. And I think on the unit right now, I only have one person with a pressure injury, and they were admitted with that pressure injury. So it has been really, really successful. Then sleep aids. We're taking a look at how many people need medications to go to sleep, the melatonin and hypnotics, and antidepressants used for sleep aids. And so in this slide here, you can see the blue, how many were taking it before, and then right after the program, it was about a month after that we measured and saw the decrease, and then later on we measured it again and saw that there was an additional decrease after they'd been on the program for a while. Next slide. So for next slide. So for ongoing, taking a look at sleep aids, because people change and come and go, we decided to use the Casper report just to measure it long term, to keep that measure going. And as you can see, we continue to be well below the state and the national average for % of long-stay patients who receive an anti-anxiety or hypnotic medication. Next slide. Next slide. Okay, well, let me just go on to depression was one of the next things that we measured. And for the depression, we looked at the PHQ-9 score, and for that one, I don't know why the slide's not changing, but we looked at it in the fourth quarter of 2016, which is right before we started the program. There it is. And you can see where we started the sleep program right away. The quarters following the sleep program, our depression scores decreased. Okay, next slide. And then this was the Casper report, and as you can see, continued to be well below the state and the national average for % of long-stay residents who have depressive symptoms. Next slide. So for cognition, this is one we used from the MDS, the BIM score, and I was really surprised because people do naturally lose abilities, or at least I thought that way after they grow older. But what we found was that indeed the average score increased instead of decreased once we started the sleep program. Next slide. So on the next slide, a sleepover. What happened was I decided to stay in the facility on the long-term care and record the number of times I was woken up before the program and after, and I was woken up 22 times before the program started and only 10 after, and I have to say the times I woke up afterwards, the sleep program started because my roommate was coughing. Later on I found out she had the flu only because I ended up with the flu. So there you go. So next slide. We measured our satisfaction as well, and it just has gone up and continued to go up. Currently we're at 94.6% for our satisfaction, and we're using the advocates to measure that. So the cost of the program is on the next slide, and we actually found that we saved money going to the program. We thought we were going to spend more because of the nighttime briefs, but as you can see, and you can see what the cost of each of those things. Most of them we got on Amazon, I have to say. But the briefs themselves, if you can look down below, in October, November, we were spending $6,000 on briefs. Those weren't the nighttime briefs. It's just regular briefs that we used before. In January and February, we only spent $4,000. Even though the overnight briefs were more expensive, we used less of them, so we ended up with a total savings. So if we take a look at the summary of this on the next slide, you can see that we decreased the number of falls, the number of skin issues, the number of times that I was woken up, the number of sleep aids, depression went down, brief costs went down, and we increased cognition and satisfaction. And so, next slide. And so one of the things that we talked about in the collaborative was sustainability, and I have to say when we got to this topic, I thought, ooh, we didn't think about that when we started. We didn't have any champions. We didn't have the program in new orientation, and new residents that came in weren't being assessed. We forgot to think about keeping the program going, so all of those things were added to ensure the gains were being held. And next slide. So one of the things that started this whole thing out was that AHRQ nursing home survey. So on this next slide, you'll see that 1 year later, that same question we increased by 5 percentage points. It's easy to make changes to improve resident safety in this nursing home. 13%, this nursing home is always doing things to improve safety. 27%, staff get the training they need in this nursing home. And 28%, staff have enough training on how to handle difficult residents. I think that just doing that one project just really increased the whole safety culture of our building and the way the staff perceived how we were handling the change in our nursing home. So thank you. And I'll turn it back over to Leah.
Thank you, Margaret. We were so impressed with what you guys were able to achieve through what you learned in the collaborative and how you applied it to your sleep program. And you just seen some amazing results. And we do hope to have some questions, but we're going to do that at the end of the presentation after Deb has given her presentation. So if you have questions for Margaret, please put them in the chat box, and we will address them at the end of the presentation, and we'll also open the lines at that time. But at this time, I would like to introduce Deb Sutton. She serves as administrator for Jefferson Community Health and Life Gardenside and Cedar Woods Assisted Living, both located in Fairbury, Nebraska. They transitioned to a culture of natural awakening 6 years ago. Deb worked in long-term care as a director of nursing for 19 years prior to working as an administrator for the previous 13 years. She has led Gardenside to 5-star recognition and a bronze commitment to quality award and has propelled it to be a leader in the undisturbed sleep and natural awakening. Deb, at this time, I'll turn it over to you.
Hi. I'm glad to be here today, and I'm going to open up by just saying that our journey into this actually was probably quite different than what Margaret's was. We really started this project as part of our QAPI team. We were participating in what was then SIMRO, and having to pick a project that we were going to work on for our quality project for the year. And what we decided we wanted to do was to get rid of our alarms. We still had audible alarms at the time. And that was about 8 years ago. And then we were very successful. We got rid of all of our alarms. We didn't increase any falls. And so our team was pretty excited, pretty pumped, and wanted to go a little bit further. And I had actually gone to a workshop that was put on regarding person-centered care. Next slide, please. That was on person-centered care. And on that, they kind of just opened up the idea of undisturbed sleep. And so I came back, kind of visited with our staff about undisturbed sleep and talked to them about it a little bit. We went on for a few months and then actually went to another workshop that was put on by Sue Ann Gilderman. And if any of you have heard Sue Ann speak, she's a wonderful speaker on the topic of fragmented sleep and undisturbed sleep. So came back again, visited with our QAPI team, and we really decided that we could do this. And so we started off our journey by pulling the right team together and by educating ourselves. And so we made it a requirement for all of our team to watch the webinar that had been recorded through our Quinn, to watch that and to come back and we talked about it. So we really didn't approach it as a program. We approached it as a total culture change, just completely reframing our thought processes on what we do and why we do them. One of the biggest things that we talked about was falls, of course, and what were the causes of falls. And the number one external cause for falls is noise. And so we had taken care of that, we thought, at least partially, with getting rid of all of our alarms. But the number one internal cause for falls is fragmented sleep. And so, like I said, we all participated in the webinars. We all listened to that. We actually sent out an email to our listserv that's through our Quinn asking if other facilities were doing undisturbed sleep. And we basically got nothing. We had no replies back except that, hey, this sounds like a good project. Let us know if it works. So next slide. So we decided that we needed to just dive in and start studying and learning a little bit more about it ourselves. Keep in mind, we actually implemented our change, our undisturbed sleep natural awakening 6 years ago. We are through our 6th year. We're now starting into our 7th year of doing this. So what we decided we needed to do first was educate our staff. So all of our staff, we made it mandatory for all of our staff, housekeeping, dietary, nursing assistants, all of them were required to watch the undisturbed sleep webinar presentation. After that, we had our staff meetings, we talked about it, and we decided that probably the biggest thing was the education piece of it. Understanding sleep and understanding why it's so important to focus on our residents' sleep and the quality of their sleep. So I'm going to just briefly review the stages of sleep with you. I'm sure you all know these things, but it impacts some of the interventions that we did later. So there's basically 4 stages of sleep. Some people say there's 5, but basically 4 stages of sleep. And adults need on an average 7 to 8 hours of undisturbed sleep a night, every night. No more, no less. But they need that 7 to 8 hours. With those 4 stages, you cycle through those usually 4 to 5 times a night. So the first stage being stage 1. Stage 1 is that very light sleep. When you're first falling asleep, you're very easy to wake up. It lasts about 5 to 15 minutes, and it's just a transitional stage that helps your body start to slows down your brain activity. And this is the part where if you ever have woken up, you wake up very easily out of the stage. So if you ever woken up feeling like you're falling, you're in stage 1. Stage 2 then is where the muscular activity decreases even more. The eye activity kind of stops or slows way down. Heart rate slows way down. The person is still fairly easily aroused from this stage, but not as easily as they were in stage 1. Stage 2 is 40 to 60% of your total sleep. So quite a bit of our time is actually spent in that stage. Next slide, please. Stage 3 of sleep is your deep sleep. So stage 3 is an important part of your sleep. Only 5 to 15% of your total time sleeping is actually spent in stage 3, but stage 3 is where all of the healing occurs. So that is where you have the healing of the tissues, regeneration of the blood cells. This is where you have the reoxygenation, cellular repair on the basic level. So this is where your muscles heal, your wounds heal, your immune system restores itself. Deep sleep reduces sleep drive. So that's kind of an important thing to just know here, that if you're getting into a good deep sleep, it decreases your need to sleep. So when you're talking about naps, and that's going to be something we talk about later, when you talk about naps, if you take a nap that's 20 to 30 minutes, you are probably not getting into your deep sleep stage. So that's a good rejuvenating energy power nap. If you allow yourself to get into the deep sleep stage of your nap, then you actually are making it harder for you to sleep later on in the day. So this stage is really, really important when we're talking about pressure sores and healing of wounds and immune systems and infection rates, those kinds of things. Next slide, please. So the next stage of sleep is REM. And we've all heard about REM sleep. That's the rapid eye movement sleep. That's where our heart rate goes up, our eye movement goes up, our respirations get very rapid, but irregular and shallow. REM is associated with healing of emotional and psychological health of the body. They actually have determined that people who suffer from PTSD fail to enter into REM sleep. So REM is very important for solidifying all of our day's events. Our memories are solidified in our REM sleep. So our deep sleep stage, where our deep sleep starts off, the longest amount of deep sleep is actually the first stage of deep sleep. Remember I said it cycles 4 to 5 times through the night. So that first cycle of deep sleep is your most critical. That's your longest. It's just the opposite for REM. You have very little REM sleep at the beginning of your sleep, but your REM comes in and your REM is longer towards the end of your 7 to 8 hours of sleep. So REM is important for storing all the memories and helps the brain to consolidate and process everything that happened to you that day. Next slide. So, like I said, adults need 7 to 8 hours, no more, no less. Fragmented sleep, Margaret had touched on the fact that fragmented sleep does a lot of bad things to us. It decreases our alertness. It makes us more irritable, loss of emotional control or anger. We become more short-tempered, disorganized thinking, memory loss. And if you look at those symptoms, those are the same things that we describe as dementia. And too often we have treated people for dementia that what they're truly suffering from is fragmented sleep. So very, very important to understand all of the effects that fragmented sleep has on our immune system, our ability to heal, and our cognition. Sleeping more than 9 hours also has some issues. So it can lead to postural hypotension. It can lead to dehydration and increased UTIs, confusion, depression. So it's important to have the right amount of sleep, but not too much sleep. Stage 3 usually begins 60 to 90 minutes after we've gone to sleep. So remember I said that that's where we do the most healing, and the very first session of deep sleep is the best. It's the longest, it's the best. You know, what we have done as nurses for years and years and years, because it's what we had, it's what we were taught, was you needed to check and change everybody, every 2 to 4 hours. So if we're going in every 2 hours and repositioning and checking people, it's typically taking them 15, 20 minutes to get to sleep. They are just getting into their stage 3 sleep when we're going in and flipping on the lights and turning them and waking them up and defeating that entire purpose, that healing period that they need to have. Melatonin, I'm just going to mention it quick here, it's the sleep hormone. Melatonin production peaks when we're 25 years of age. And I can attest to this. When I was a young nurse, and the older night nurses always talked about how they just can't sleep. They have to get off of night shifts because they just can't sleep. I couldn't understand what they were talking about because I could sleep in an auditorium with 1,000 people. It didn't make any difference to me. But now that I'm well over the age of 50, I'm having more trouble sleeping because my melatonin has decreased by 50%. And by age of 75, our melatonin production has decreased by 75%. So that significantly impacts our ability to get to sleep and to stay asleep. Next slide, please. So what our group did is we sat down and we looked at the top disturbances of sleep. And we broke this down according to how things worked at Garden Site, what we saw in our home in relation to all of these things. So we looked at noise, we looked at our lights, we looked at the sleep environment and napping, medications, continence needs, pain, positioning, inactivity or activity, and diet. All of those things are those are the top 10 disturbances to people's sleep. So we looked at each one of these and broke them down individually to see what we could possibly do and how we could impact this. Next slide, please. So the first thing we did, like I said, we made it mandatory for all of our staff to watch the webinar on undisturbed sleep. After that, we got together, we picked a dedicated team. On that team, we included housekeeping, maintenance, laundry, dietary, nurses and nursing assistants, activities, and social service. Everybody was on that PIP team. We sat down and we did what we call the sticky note challenge. So we wrote down what all of our biggest fears were of going into this, and what we thought our greatest challenges were going to be, and what excited us most about this. And, you know, the enthusiasm that I had from our staff was unbelievable. They were all like, we got to do this. I mean, there is no reason we should expect less for our residents than we expect for ourselves. And we talked about the fact that when you have a baby, and your baby, if you've ever been new parents, your baby first sleeps all night for the first night, we celebrate that because they slept all night. And we don't think, oh my God, I have to go wake them up every 2 hours and check their diaper because they may have skin issues. I mean, it just is a no-brainer. And we looked at this and said, we need to provide the same courtesy to our elders. Like I said, we met with dietary, housekeeping, laundry, maintenance, anybody that would be affected by this. And the first thing we did is we changed the noise in our hallways. So we talked about the fact that we have silent times. So we have a silent zone in our hallways from 8 until 8. And we actually changed the times a little bit. It's 8 to 7:30 now. But we turn all of our hallway lights off except for our emergency lighting. We do not allow any carts down our halls of any kind. Not med carts, not laundry carts, not maintenance carts, not housekeeping carts, nothing goes down our hallways. We decreased the traffic in our hallway. We even changed the main entrance for where our staff entered and left work because we found out it was at the end of one of our resident hallways and it was disturbing people at night. Next slide, please. The next thing we did is we looked at our sleep surfaces. So we had kind of tackled the noise part. We looked at our sleep surfaces, and we were fortunate in the fact that we already had really good pressure redistribution mattresses on all of our beds. And we already had 2 low air loss alternating pressure mattresses, but we purchased 2 more. So we now own 4 low air loss alternating pressure mattresses so that if we have a resident that we feel really truly does not do any weight shifting, which those are very few and far between for us, but if they really truly don't weight shift or they are extremely high risk for skin issues, then we place them on those mattresses. The next thing we did was we brought our tenor rep in, and I am not a tenor rep. I get nothing from this, but we're very, very picky about the briefs that we use, and that is the brief that we have found is the most absorbent, has the best outcome for our skin. So we had our rep come in. She actually went down the hall with all of our nursing assistants and made sure we had every single resident in the correct brief. And then we also talked to the staff about who were the residents that had the heaviest incontinence issues at night, and we made sure that they were in overnight briefs, kind of like Margaret alluded to. Not everybody went into an overnight brief, but we certainly had some residents that did go into overnight briefs. Then we decided we really didn't know what our next step was, so we just kind of jumped in and we talked to our night shift, and we stopped waking residents up at night. So we didn't change anything on our day shift yet. We just went to we didn't wake anybody up at night. And what we found out is that we had a few residents that were wet in the morning. So we started sleep logs. And what we were tracking is what time did that resident go to bed, what time did that resident get up, and how wet were they? Was it just the brief, or was it the bed clothing? Because if it was just the brief did its job. We were happy. If it was the bed clothing, then we needed to make some adjustments. We had a few residents that requested to be awakened to go to the bathroom at night. And then after we reviewed sleep logs, we found that we had a few people that they went to bed fairly early at night. And so we did end up waking them up one time during the night to go to the bathroom. However, we have a 6-hour golden rule in our facility, and we absolutely do not wake anybody up until it's been at least 6 hours of undisturbed sleep. So that's why it was important to know what time they went to bed. Because some of our folks go to bed at 10 or 11, some of our folks go to bed at 7 or 8. So those times were very, very important for us. So we established very individualized sleep routines for them. Some of the other things we looked at is we had horrible pillows. We talked about when we go somewhere to a hotel to sleep, what are the things that impede our sleep? And of course, noise in the hallway was one of them. Lights that come under the door were one of them. One of them was pillows. And we have those disgusting, crunchy, cleanable pillows that most hospitals and a lot of nursing homes have. And so we decided we needed to do something better. We actually bought hotel quality pillows. So we now have an option of firm, soft, and then crunchy, because we had a few of our residents that wanted those crunchy pillow sacks. So we have a choice of those 3 pillows that we can now offer all of our residents, and we do that upon admission. We talked about whether or not we were going to have to change our staff schedules, but we found out we didn't, because we were actually starting to talk about not waking people up in the morning, and we didn't know how that was going to impact our day shift. Just like Margaret's group, we stopped stocking at night. Nobody went down the halls and stocked things during the night. Nobody put out towels and washcloths during the night. We decided we could do that before anybody went to bed, and we could do the stocking part on day shift. So we changed all of those routines. The other thing we really did that isn't on this slide is we added an evening activity person. So we have a full-time day shift activity and a full-time evening shift activity staff. So we have activities 5 nights a week, and they have activities that go until 8:30 at 9 o'clock at night. And the residents love it. We found that residents were way more engaged. They stayed up. They didn't go to bed as early. Therefore, they were sleeping better at night. We also added a sensory cart. And on our sensory cart, we put in, we have a happy light. So if we have people who we feel like need more serotonin during the day, we can get this happy light out, and that's what it's called, a happy light. We have aromatherapy, and we have more than just the lavender, because we found some residents didn't like that smell. So we have different scents that we can get, and we have the diffusers that we can put in each individual resident's room. And we also added weighted blankets, which we found very quickly our weighted blankets, our residents either loved them or they hated them. So they're not for everybody, but for the residents that love them, we had one lady who actually described it as feeling like she was being hugged. She loved it. It was a very secure thing for her. But the weighted blankets are something you need to research if you're going to do weighted blankets. We too changed our overhead lights. We took all of our night lights in our bedrooms, our resident rooms, and we put amber lights in them instead of the LED lights like we had. We have LED in the hallway, but we have amber lights in their rooms. And then we too put the same kind of neck lights on our staff at night, so when they did have to go in to attend to somebody, they didn't have to turn on overhead lights. So there's no overhead lights that get turned on unless emergency situations. Next slide, please. So then we decided we kind of had gotten this far and things were going fairly well. So the next step was we were going to stop waking people up in the morning. And we just did it. We just went in and we picked a day on a Monday and said, okay, here's the day we're going to do this. I need to back up. One of the other things that we did is we did change, and it's on this slide, we did change our breakfast times. And we worked with dietary to change our breakfast times a little bit, recognizing that we may have to be a little more flexible with our breakfast times. So we changed to offering hot breakfast from 7:30 until 9. So at any point in there, they could go to the dining room and get a hot breakfast. Before that time or after that time, we put things in our kitchenette for the residents where we could provide continental breakfast for those residents. But we just picked a day and we stopped waking people up. And talk about culture change and really, really challenging the staff. That was a bigger challenge than it was for my night shift staff because they didn't know how, they didn't have a routine. And they will tell you to this day, they still have no routine. Every day is different. Some day residents wake up at the same time. Some day it's very, very much a trickle effect. But you will find out that if you would visit our facility, our hallways are quiet at 7:30. There's a few people up, but not a lot of people. And as people start to ring and call for assistance, then our staff go in, or as we walk down the halls and check on them, then we see that they're rousing, we go in and we help them get up for the day. So what we found out with that was, that of course affected housekeeping because housekeeping now couldn't go in there. We didn't have everybody in the dining room bright and early at 8 o'clock for breakfast. So we had to look at how we were going to staff the dining room. We also had to talk to housekeeping about, we had to be in communication with them on which rooms they could go into and which rooms they had to wait to clean. They were great about it. And I'm trying to think of, our restorative aid, our restorative department had a little bit of culture change there because her office is down, that area is down a resident hallway, and so we had to change our restorative time. So we didn't begin restorative. We used to begin it at 7 a.m. We now begin it at 8 so that we're not disturbing those residents that are across the hall. Next slide. So what we found out is, and what I share with people, is that we had a lot of positives and we had a lot of negatives, things that we could have and should have done differently. One of them was med passes. So everything went pretty well. We decided that we needed to change our med passes so that we decreased the number of times that we were passing meds to residents. And we also wanted to significantly decrease the medications we were giving in the evening because we were trying to decrease the amount of fluids that our residents consumed in the evening to decrease their incontinence episodes. And we also did not want to wake any resident up for any treatment or any medication, if at all possible. And for the most part, we have been very, very successful at that. The one thing I would recommend is we didn't start that process early enough. And so that was probably our biggest learning thing, is that we needed to start changing our med passes much earlier. Next slide, please. So we did have some fails, and we had some errors and some learning curve on that. Next slide. There's also, so what I want you to know is that on the slides, there's a lot of things on here on other things that we did, changing our lighting. One of the things was our HS cart and adding snooze foods to that, such as sleepy time tea and the nuts and the whole grains and the potassium-rich foods, carbohydrates at night, and offering more proteins in the morning. There's a ton of things that you can do that do not cost you anything and that do not take a lot of effort. It is a mindset change. It is a total different way of seeing what you do and how you do it. But what it has been for us is it has been a bigger bond with our staff and our residents. Our staff now do an assessment on admission, asking our residents, what do you prefer for waking? When do you like to go to bed? What kind of sleep environment do you like to have Do you like it warm? Do you like it cool? Do you like a fan? Do you want noise? Do you not want noise? It really, truly has brought our direct care staff and our nurses closer to our residents. Our residents have loved this. Our state surveys, we are getting ready to go into our 7th survey. We're due anytime with this already in place, and our residents love it. And because our residents love it, our surveyors love it. We've had no problems. We actually, as far as outcomes, we have 0 antipsychotic use. We have 0 pressure sores. We did not see any negative outcomes related to this whatsoever. Our falls with injuries decreased. Our behaviors have decreased. We've had really significant success with this, and we've been able to sustain it. I guess I'm going to close because I'm running out of time, and I apologize for that. But my favorite quote is, I did then what I knew then, but when I knew better, I did better. And this is something that I would love to see as a norm in our nursing homes across the nation. It has worked for us. Our staff actually had a couple of days where we had water that had to be turned off early to work on some things, and we had to kind of go back to the old way of doing things. And my staff all came to me and said, we never want to do this again. Our new way is way more unpredictable, but it is so much better, and it is so much more resident-friendly, and we feel like we're not doing justice to them when we're going in and waking them up. So it is doable. We're open to any questions that anybody has, and at this time I'll turn it back to Leah.
All right. Thank you so much, Deb. I'm so excited about your program. I'm going to skim through the rest of your slides, but I want everyone to know that there's a lot more content in here that you can look at later. We will be sending the slides out after the presentation today, so feel free to take a look at that at your leisure. And Deb's contact information is on the screen now, so you can feel free to contact her. And both of these nursing homes have done an excellent job in implementing a new sleep culture in their communities, and obviously the residents have thrived under this programming. So, and this culture. And Deb's absolutely right that this is a culture shift and a new way of doing things. So, at this time, Vanessa, can you remind people how to ask a question on the phone?
Yes, of course. We will now take your questions. You can submit a phone question by pressing star, then 1 to enter the queue. And if you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. So I'm standing by for phone questions. Please press star, then 1 if you'd like to queue up.
Thank you so much. While we're waiting for phone questions to come in, Crystal, you've been monitoring chat. Are there any questions in the chat?
Yes, there was a question for Margaret where someone wanted her just to explain the mood lighting again.
So for the mood lighting, what we did was we changed our hallway lights to a lower voltage and then put on every other one instead of the whole row of lights. It's just dimming the lights, basically.
Okay, and then I think this question is for Deb. Do you have CNAs assigned to cards or certain residents, or do they just all work together since the wake-up times are so different each day?
Our staff, we do primary assignments, and we've done that for years and years. So we have two nursing assistants for each neighborhood, and there are 20 residents in each neighborhood. And so they just work together to get up everybody on their neighborhood, and then when it's time for somebody to go to the dining room, then they all just pitch in and they work together with all of the neighborhoods.
For Margaret, how did you do the infusion down the hallway with the lavender infusion?
So the lavender infusion was battery operated. We just put it on a stool halfway down the hallway.
Okay. And Deb, I believe this question's for you. How did you change the elders' routine when it came to the open lunch and open dinner times like breakfast?
Actually, we didn't have to change their routine. Our residents, one of the things we did different with open breakfast is we served as people come in. So as they come in, they are served their meal and their drinks right away. rather than our old way of doing it was we waited until everybody was in the dining room at 8, and then we served a table at a time. So you may be at table 10, but had been the first one in to the dining room, but if they started that week with table 1, you were one of the last people served. We totally changed that when we went to open dining, and so they were served as they come into the dining room, and our residents loved that so much that about 6 months into it, they asked us if they couldn't do that for all their meals. So we now have that open dining concept for all 3 meals because that came as a resident request through Resident Council.
Vanessa, do we have any on the phone?
I am standing by for phone questions, but as a reminder, you can press star, then 1 if you'd like to queue up.
Okay, here's another question in chat regarding the CNA shift schedules. What are the schedules that you use for the CNAs?
Is that Margaret or for Deb?
It doesn't say.
I can tell you ours, and then Margaret can give you hers.
Yep.
We use a combination of our main shift is 6 to 2 and 2 to 10, and then we have 12-hour shifts in there also. And so we have staff who work 6 a.m. to 6 p.m. and staff that work 6 p.m. to 6 a.m.
Ours sounds similar. We do 6 to 2, 2 to 10, and 10 to 6.
Okay, great. I believe this may be for Deb. When do you do your baths, before or after meals? And how do you maintain staff in the dining rooms if the staff are getting people up during all hours of the morning?
That's a great question. That was one of our biggest challenges. As far as baths, we have people who do baths for 10 hours during the day, and then we also have 4 hours in the evening. And we go to our residents when they're admitted, and we ask them what their preference is as far as the bath time. And some residents will go to the dining room in their robes and their slippers, and some residents choose to not do that. So it is entirely up to them what time they want to take their bath and if they want it before breakfast or after breakfast. We did have an increase of residents that wanted room trays for breakfast just because that's what they wanted, and we do accommodate that. And as far as, what was the other part of that question? It was dining room. So in the dining room, what we ended up doing is our nurses now are not crazy in the morning trying to get all their blood sugars and all their things done. So we actually have a nurse that goes into the dining room at 8 a.m. She has to be in there at 8. And we don't take our assisted residents down until 8. So at 8 o'clock, we have a nurse that is in the dining room. And all of our activity and social service staff are all CNA certified. So I have a social service staff that also joins her in the morning in the dining room. And then as soon as we have a CNA that is available from one of the 2 neighborhoods, they go down to the dining room and relieve one of those 2. So it's kind of a team effort. And we have walkies. So if we're needing additional help down there, we just call and ask for help.
All right. Thank you, Deb and Margaret and everyone for attending today. If you have questions, please feel free to reach out to any of us. Slides will be provided via email after the presentation today, and the recording will be available in a couple weeks so you can share it with your colleagues. So thank you, everyone, for joining our presentation today on a quality sleep culture, and I wish you the best of luck implementing some of these cultures into your own community. Take care.
And thank you, ladies and gentlemen. This concludes our conference. We thank you for your participation. You may now disconnect.